So good afternoon, everyone. I'm Jeff Drazen, editor of the New England Journal of Medicine, and this session is NEJM World Economic Forum co-sponsored. So even though the number of people here isn't terribly big, we're being webcast, so there are likely hundreds of thousands of people tuned in on the World Wide Web. So what we're going to do is talk about visualizing disease, and the diseases that we're talking about are non-communicable diseases. So I graduated from medical school in 1972, 45 years ago. And at that time, one of our professors said, you know, if we can get rid of parasitic diseases and bacterial diseases or get them toned down, the health of Asia would be tremendously improved. Here we are in 2017, and we've really got control of parasitic diseases. Not completely, but a lot. They're not a major killer. And you know what happened? Something else emerged. Non-communicable diseases, much harder to deal with. A lot harder to deal with. And how they've come about, how they've worked their way across Asia, in fact, across the world, is part of our story. So what we're trying to do this afternoon is to give you an idea of how that's happened and what impact it's had on the Chinese society. And to start off with the epidemiology, the description of how this has happened, our first speaker is coming soon, is Juliana Chan from the Chinese University of Hong Kong, professor of medicine and therapeutics. Juliana, so you want to give us the story of how these NCDs, as we call them, have moved their way across?
Thank you. The clicker. Do you have the clicker? Yeah. Thank you. Good. Thank you. We are living in an ever-changing, rapidly changing, and interconnected world where social, economical, political, and technological changes are having enormous impacts on all aspects of life, including health and wealth. In less than 20 years, Shanghai has been transformed from a piece of farmland to one of the cosmopolitan cities in the world, with all its implications on the way how we live, how we eat, how we move, how we sleep, how we choose, and how we want and feel. In the last 3 decades, the GDP of China has gone up from 4,000 to 40,000 renminbi. This is accompanied by the increase of diabetes prevalence from less than 1% to 11% during the same period of time. Diabetes is more than a disease due to unhealthy eating or not enough exercise. It is an exemplary example of how rapid societal changes is transformed into a personal challenge requiring a societal solution. In emerging economies like China, rapid urbanization has created a weight-increasing environment promoting obesity with a lot of skyscrapers, automobiles, mechanization, bioactive pollutants, excessive use of alcohol, smoking, and also energy-dense processed food. In some communities, these rapid changes in lifestyle has disrupted traditional way of living and also created social disparity, which actually puts many of those disadvantaged and also genetically susceptible, very vulnerable, as they struggle to lead a new way of life in this rather unfamiliar world. Life is all about energy. And when you talk about energy, then we are talking about effective management of blood glucose, which should be kept between 4 and 8 millimoles per liter at all times in order for effective energy storage and utilization. This is the pancreas, which weighs only 60 grams, which is the size of a golf ball, lying silently behind the stomach. Within this tiny organ, 90% of the cells secrete digestive juice, and only 5 grams, which is less than a teaspoon of sugar, form the islets that will secrete insulin on a minute-to-minute basis to maintain that glucose within that very narrow range. Thus, abnormal architecture of this pancreas islets and also abnormal regulatory mechanisms will actually make a person's blood glucose fluctuate with whatever he does, whatever he eats, and whatever he thinks. And these fluctuations of blood glucose level would destroy all blood vessels and also nerves in a silent but sure manner to destroy all organs, including but not limited to heart disease, stroke, kidney failure, cancer, dementia, and premature mortality. Globally, 1 in 11 adults have diabetes, and the majority of them are actually not diagnosed. 1 in 7 pregnancies are affected by gestational diabetes, and 500,000 of children had type 1 diabetes, and without insulin, they would die. Currently, we spend 1 in 12 healthcare dollars are spent on diabetes. And the majority of this is on complications, which are preventable in the first place. By the year 2040, there will be 600 million people with diabetes, which is the size of half of the population of China. And the majority of these will come from low to middle income countries who have the least capacity to deal with this human disaster, which is killing 1 person every 6 seconds. Yet, diabetes is highly preventable and also treatable. A story of twin sisters that I personally know, explaining it all. Both of these twin sisters were diagnosed to have gestational diabetes at the age of 30, and both of them developed diabetes at the age of 35, and both of them refused treatment in the first few years. But the one living in Hong Kong was finally persuaded by the relatives to seek management in a multidisciplinary diabetes center, where she learned about the what, why, and how of diabetes and adopt a new way of life. At the age of 50, she's well and alive, treated with multiple medications, including insulin. And she's expected to live to the age of 80 or beyond, with the support from her friends and relatives and care team. But sadly, her sister recently died at the age of 50 with kidney failure and stroke because of poor adherence, fragmented care, and less social support during these 15 years of illness. Thus, diabetes is highly preventable and treatable, and indeed, over the last 3 decades, we have learned a lot about the causes and consequences and treatment of diabetes. In the early 70s, researchers in China have already reported that using structured lifestyle modification to improve physical activity and also healthy eating, we can reduce the risk of diabetes by 40% and delay the onset by 10 years in middle-aged men with pre-diabetes. 23 years later, this was translated to 20 to 40% reduction in cardiovascular disease and also death. In the early 80s, researchers from Hong Kong have reported the exceeding low death rate in 80 subjects with type 2 diabetes and hypertension, participating in the clinical trials, receiving structured care by a stable doctor-nurse team with good management of risk factors, with only 3 deaths in 7 years. This is in contrast to 24 deaths in 80 patients with the same clinical profile being managed in the same hospital, but in a busy clinic where care is more random and fragmented, indicated that team-based structured care can make a big difference to these high-risk individuals. Thus, prevention and good care can make a difference, save life and save money. But the reality is the majority of people with diabetes and prediabetes are not diagnosed, treated, and controlled. So the challenge is to devise an innovative solution where we can identify these individuals early for proactive management by the right team at the right time and the right setting. And I think this is really where genomic medicine may offer an avenue to enable identification of these high-risk individuals and distinguish them from their peers with similar clinical profile in order to start an engaging and personalized conversation to motivate behavioral changes and to start treatment if early, if necessary. In China, a 40-year-old middle-aged man who smokes, got a family history, and also a bit of overweight, his lifetime risk of diabetes may be 1 in 4. But depending on his genetic makeup and the interactions between the modifiable and the unmodifiable risk factors, the modifiable being mainly smoking and obesity, his lifetime risk of diabetes may range anywhere from 10% to 60%. Indeed, prediction, prevention, personalization, and participation is what we're really yearning for. Each person with diabetes has a unique set of profile, with 1,000 patients having 1,000 stories and 1,000 outcomes. By having a good registry, we can track these critical factors over time to unravel the complex interactions of these risk factors on clinical outcomes in order to stratify risk and triage care. At the same time, if we can empower the care providers and the patients with these risk profiles and actionable items such as blood pressure, glucose, body weight, and lipid, we'll be able to reduce clinical inertia and also poor adherence. In this joint Asia Diabetes Evaluation Program, which is a web-based tool with built-in protocols, a validated risk engine, a personalized reporting, and also decision support, we're able to change the workflow together with the team and augmented by information technology to visualize risk and to motivate behavioral change and to individualize care to make a difference to these patients' outcome. So in this era of fourth industrial revolution, innovations such as artificial organ, artificial intelligence, precision medicine, stem cells, wearable devices, robotics, and so on, give great promise to improve life, to protect health and prevent diseases. We must not forget that we must use multi-sectorial partnerships to create a sustainable and also a health-enabling ecosystem, a caring and also a just society, and an affordable and integrated healthcare to bring out the best of these technologies to preserve humanity. It is here where the government must take the leadership role to use mandates and fiscal measures to protect the environment, to make sure that the citizens have exposure to safe water, safe air, and safe food, and build healthy cities to promote healthy exercise and also healthy eating. Like food and shelter and clothes, health is a basic human right, and these people should have access to basic care, essential medications, general and also health education. While the government will continue to nurture the environment to promote interdisciplinary innovations through partnerships of innovators, knowledge workers, industry, and foundations, they must also protect the disabled, the disadvantaged, and also some of those disillusioned. It is only by embracing this diversity, creativity, and humanity will we really realize the vision of using interdisciplinary innovations for the holistic development of mankind. Thank you.
So Juliana talked about diabetes as a representative example of a non-communicable disease. We have heart disease, cancer, chronic pulmonary disease, chronic kidney disease. All these are non-communicable diseases that pose a big burden on the population. David Cook, who's Chief Operating Officer for Jiahui Health, is going to tell us about cancer as another example of non-communicable diseases that have a burden on the Asian population. David?
Thank you, Jeff. The opportunity to address non-communicable diseases is greater in China than anywhere else in the world. To design the solutions that are appropriate for a population of 1.3 billion people, we have to understand the boundary conditions that define the types of solutions that will function within and around those boundaries. The scope of the problem of non-communicable diseases in China is tremendous. 900 million is the number of people in China who smoke or are exposed to secondhand smoke on a daily basis. I live in Shanghai. There are 14 hospitals there that see more than 5,000 patients a day. The healthcare demands of China are enormous. China recognizes the problems that it faces, but demand exceeds supply. A few weeks ago, I interviewed a pediatric hematologist. She sees 70 patients in a 4-hour clinic in the morning. That's 3.5 minutes or less for a child with childhood leukemia. The frustration for both physicians and patients, nurses, everyone in the system is enormous. Part of the problem, though, in China, the data from 2015 suggest that in 2017, the healthcare system in China will process 8 billion visits. The PRC is trying to address the problem. It recognizes the problem. The Chinese healthcare system is a victim of its demographics. 131 million people have moved into an older category. There's about 114 million diabetics, and migration has moved about 270 million people into the cities. Additionally, China has done things to address its health problems that also potentially have increased demand. In 2008 and 2009, it instituted largely universal health coverage, further increasing the surges in demand. China is trying to address the problem. Since 2010, China has doubled its spending, per capita spending. And in cities like Shanghai and Beijing, it's doubled its spending again. Nevertheless, the amount of dollars that exist in healthcare constitute one of the constraining conditions in which solutions need to be created. Similarly, China doesn't have enough physicians. The number of physicians in China per 1,000 patients are about 50% less than most of its economic neighbors. The 12th five-year plan included significantly increasing the number of physicians, and it included increasing their training. But it's going to take at least a decade to bring those resources up to demand. China has also recognized that physician training in China has not been adequate. Demand has surged, but the system is still a legacy system in some ways. 44% of Chinese physicians don't have a bachelor's degree, and only 12% have a graduate degree. China is changing this. It's mandating higher levels of education. But again, if you've got 2.5 million physicians in a country, it's going to take 10, maybe 15 years to address this knowledge gap. So there's a capacity gap, there's a financial gap, there's a knowledge gap, all of those. as Juliana said, physicians don't have enough time. They don't have enough time to develop a care plan. They don't have enough time to manage patients longitudinally. They don't have enough time to educate. They want to do these things. And they don't have time to make a proper diagnosis, which is a cognitive skill. So 53% of diabetics in China, at least, are undiagnosed. Cancer is the #2 killer, #2 chronic disease. And cervical cancer is probably the most preventable and curable of cancers. But in China, cervical cancer needs attention. Currently, only 1 woman in 5 gets a pap smear. Part of it's public education. The other part of it is there simply are not enough pathology and cytology resources to do pap smears given the demand. Breast cancer, huge problem in China. Interestingly, breast cancer in China occurs 10 years earlier than in the West. Breast cancer is increasing, and when it's diagnosed, in part because of the way the health system is and because of lack of awareness, when breast cancer is diagnosed in China, it's typically 1 or 2 stages more advanced than it would be in the West. And as a result, the type of care that's provided is interventional. Too much of healthcare in China is episodic and interventional. If you look at a curve, and on one extreme is a radical mastectomy, and the other end of the extreme would be health outcomes that are superb because they're achieved through public education, through behavior change and prevention. Most of non-communicable disease care, as Juliana suggested, exists on the intervention limb of this. What needs to happen here, really and everywhere, is to move up this curve. The next step in the evolution of trying to manage patients with disease risk is screening. And it may be pap smears, it may be mammography, it may be low-dose CT for lung cancer screening. This starts to move the management of disease up a curve so better outcomes can be achieved. What's really interesting and potentially relevant in China are unique ways that are coming online of diagnosing. We're in conversations with the Silicon Valley company that does deep learning diagnosis for lung cancer. They've pretty conclusively demonstrated that their ability to diagnose lung cancer in a chest X-ray is 10,000 times faster than a human radiologist, and inter-observer variability is essentially 0. They're introducing technology with AI to diagnose lung cancer that's not otherwise visible on CT. These things move healthcare management from intervention to screening to identifying almost the precursors of disease. And I would probably put the future of liquid biopsies in here as well. All of these things are moving the care model from intervention up to prevention before disease is established. However, these things are expensive. They're especially expensive in a country this size. Demand for healthcare always exceeds supply. When we have to figure out ways that we're going to address the overwhelming demand. So a paper was published a couple of years ago that said about 120 million women in Shanghai or in China need a mammogram. For China to do 1 mammogram on every woman that needs it, the line would be 40 years long. That's the magnitude of the demand. So we have to figure out how we're going to allocate scarce resources, whether they're laboratory or diagnostic, to a population of this size. This is a risk curve, theoretical risk curve for breast cancer. 120 million women. Number of patients would be on the vertical axis and risk is on the horizontal. Most patients have low or intermediate risk for breast cancer, and certain segments are at high risk. A curve like this for a population really represents an amalgam of dozens or hundreds of individual risk profiles. Currently, as best as can be determined with the databases that exist, 13% of cancer patients are in registries. To tackle these sorts of problems and decide how to allocate resources, to decide who goes to the front of a 40-year-long line, to decide who needs a $2 drug versus a 2-cent drug, what we need to do is develop very large databases in this country on which analytic engines can start to do risk prediction. China is the place to do this work. China has the population. China has the disease burden. China has the computing power. China has, in some ways, uniquely, the political continuity to tackle problems of this type. So I would invite anyone in the WEF or anywhere in healthcare who wants to address non-communicable disease to direct their attentions to China. Thank you.
Thank you, David. So we're going to invite our group. We have David and Juliana, and we have two other discussants, and bring the chairs up to figure out how we should approach this problem. We've thought about some questions that we want to discuss among ourselves about the best way to consider the NCD problem in China so that we have an understanding of how to allocate resources. Put yourself in the seat of a health minister. A country like China, you're spending $400 per person. How would you allocate that money to get the most information, the most useful information out of the people who are, pardon me, not out of the people, but out of the population, so you can create the best health? So you've heard from David and Juliana. We also have Richard Nieman and Mike Moradi. So Richard, just introduce yourself.
Thanks, Jeff. Hello, everybody. I'm Richard Nieman. I'm a respiratory physician by training, and I'm currently the global medical officer for Teva Pharmaceuticals, a hybrid company that is the world's leading generics manufacturer, but also has a number of innovative therapies. And I'm also a visiting professor at the Fudan School of Public Health in Shanghai. A great pleasure to be part of this panel.
Mike?
I'm Mike Moradi, diabetes advocate and biotech entrepreneur. I'm founder and CEO of a company called Sensulin, which is developing a next-generation insulin for type 1 and type 2 diabetes.
Based in?
San Diego.
So we've heard about the problem of, at least we heard a lot about diabetes, we heard a lot about cancer. Didn't hear that much about heart disease or lung disease, but they're out there. So how do we train our next generation of healthcare workers to deal with the problem? Can we make a difference? You know, you showed us a graph of education. Do we want to have highly educated physicians and a smaller number of them, or do we want to have lots of people that can screen the population and then filter out the ones that need more care? How would you deal with this population problem?
If I could, Jeff. If you simply look at the ratio of physicians to the population, ultimately the number of healthcare providers who are sort of physicians need to be increased by 50%. Chronic disease needs to be managed locally. And what I mean by locally, I mean in the communities, and I think Juliana can attest to that. one of the greatest successes in human public health was the Barefoot Doctors Program, which essentially constituted public health workers. And I think that even though we can offload some of the cognitive or diagnostic burden with AI and things like that, we also have to work from the ground up, and probably educating large numbers of public health workers is going to be central to dealing with a problem of this magnitude.
Yeah, I think this is really where we need a combination of strategies. Information technology, where a lot of the guidelines, for example, simplified, and then care protocols, doing the right thing at the right time, getting those data, and then helping the doctors to make decisions. And at the same time, it's important that I think these doctors and care providers, for that matter, get that data back so that they also learn how they are performing. Because I think without information, the patient cannot change their behavior. Without the information, the doctors cannot make decisions. And similarly, without that information, the payers cannot pay for the value of that health care. And I think, on the other hand, I think we cannot just have information, the technology, but this is really a very humanity thing. It's a very humanistic thing. Just the nuances, the listening, the talking, the persuasion, and I think this is really where you need to have a high-tech, soft touch. And I think this is really where some of these paramedical nurses, dietitians, or even some of the healthcare assistants or university graduates can be trained to do this and put them in a team and a setting. And they start learning from one another with the patient at the center. And I think, where you have this setting, then you can start doing outreach programs, start actually identifying high-risk individual, family screening. It's easy when these diseases are very early, just changing lifestyle, diet, etc. But some of them would deteriorate because of genetic or whatever, and you give treatment early. So it's just really, you need an environment and the team, and then that ongoing information collection, and using that information to help people change. So, and then once you have that kind of care models, then you can start training the next generation of doctors and healthcare providers. Because currently, I think sometimes they can't see it, right? They don't know, it doesn't happen, right? So I think, but this is a complex issue because you're dealing with healthcare system, and every country, every area is different. And that's why I think sometimes you need champions to try and set up some prototypes, share those best practices. And then, hopefully we will create a new trend of chronic disease management.
Can I just add to that? I mean, one of the challenges, I think, also is that this needs to start early. So, starting at medical school, the curriculum at medical school, whether it's in China or anywhere around the world, is so overburdened. There is so much to learn. But the emphasis on public health, disease prevention, is not necessarily given as much time as maybe it should. And clearly, as we've heard from David and Juliana, so much of chronic disease is preventable. I mean, and really in a very straightforward, understandable way. And maybe that emphasis is not given enough in medical school, doctors' training, and I think it's something that's easily done.
So, but is it the community we have to educate, or is it the practitioners, or both? Right? People have to come in to be screened. You had your line. Who's going to wait in line for 40 years unless there's a lot of desire to do it? So how do we get the message out to the community so they know how to improve their health? How do we show them the value of stopping smoking, of exercise? What should we be doing as a profession? In the, I don't know if you want to call them barefoot doctors, they were very successful at the time because they were dealing with minor accidents and infectious diseases. The scope has changed. Yes. Can the minimally educated doctor, will they have the community support they need? How do we engage the community?
I think this is where, maybe private-public partnerships, working with the industry. Very often the industry have that machinery, the infrastructures, where we can actually use media, and also some of these, self-assessment tools. Even now, we now have all these wearable watches. Mm-hmm. But I think you have to mobilize the community. And you can go all the way from school, for example, because really you are dealing with a life course. We are living in a changing world. And I think, you can't just change at the healthcare sector. You really have to change, other sectors. Maybe using the children to influence the parents, and the parents start influencing the children. So it's becoming everybody's business, so that, it now become the trend, right? This is, you want to have a healthy lifestyle, you want to get detected early. You might even want to know your whether you could genetic risk or whatever, so that, you are empowered with that information. It is, I think it is not easy, but we have to do it. Otherwise, it's not sustainable because, those figures are horrific. That said, I wish to emphasize that this is not just a lifestyle, because there are people who are overweight and so forth, but they have no problem. So in the end of the day, that we are dealing with a biological problem, and that many of these people do need technologies. They need medications. They need regular follow-up. And I think this is where, medical coverage, and then having affordable medications, affordable care become really important.
So, could I add something to that,
sure.
Jeff? I think that really this is the role of government. I mean, you've got you've got 1 billion Chinese. If you take the kids out, you've got 1 billion Chinese that need to be educated. A health system or pharma or hospitals, they can't reach 1 billion people. I think really, and the Healthy China 2030 thing is the beginning of trying to do that. It's really importantly, I think, the role of government to be able to reach population on a large scale.
Maybe one example, I think in 2004, I think the Irish government in Ireland banned, as the first country worldwide, banned smoking in public places. And I think it's attributed to directly to a 30% reduction in cigarette smoking and an almost 10% reduction in cancer. So, we've seen smoking bans in Beijing, Shanghai, Shenzhen, other places. So I think, there are opportunities for policy to affect directly the causes of NCDs. And I think it's just one example, as everybody is saying. Ultimately, this is going to be a partnership between everybody involved, but policy and how that's affected and how the population embrace that is clearly an important element, I think.
So do we know what to do, or do we really need to do research to find out what works the best? My son spent 7 years in San Diego, and one of his coworkers' wife developed breast cancer, and they ran the San Diego Marathon, each getting lots of people to support them to raise money. So it was a community effort to bring out breast cancer awareness and to bring in the community. So you're from San Diego. How does the community there deal with non-communicable diseases? It's a healthy living community. In fact, people say that Dalian is the San Diego of China. So,
well, part of that is just the beautiful weather. People spend a lot of time outside, very healthy eating habits in general. But to put that in perspective as it relates to China, it's my understanding that there are only 10,000 specialists in the diabetes space, which means that you have to do a lot of very clever things. But the roadmap is really not that complicated. It's my understanding also that what we call the ABC for diabetes, meaning a healthy A1C level, blood pressure under control, and cholesterol levels under control. Only 7% of patients are compliant with those standards. So perhaps it's just a matter of educating patients as to what those metrics are, and then helping patients manage those with the proper tools.
I think one of the problems is actually incentives. I think currently, I think often people are incentivized to provide expensive care and not so incentivized to provide preventive care. Education is, and I think this is really where the government, have to provide incentive scheme and also mandates and orders to make sure that, they are encouraging, cost-effective and preventive, cost-effective medicine rather than, sort of really just focusing on some of these, intervention, which are still very, very important, but we need to redress the balance. and then really trying to think about teams, right? Really getting the people, they are managed at the right setting. You don't need to super specialists seeing a sort of early case. But at the same time, you also don't want to have people with very complicated problems, right in the community. So how do you actually get, specialists and primary care doctors working closely together? And I think this is really where a kind of structure, where you have defined processes, defined criteria, where people know what to do at the right time in order to, get those targets. Because it has been shown again and again, if you have those targets, you do reduce the risk. But it's easy said than done because there's so many people involved and the whole thing are so silent that if you don't measure, you don't monitor, then you don't know.
Can I add something to that, Jeff? China has built community health centers all over the country to try to address non-communicable diseases. However, they're really underutilized. Since 2010, visits to CHCs, the community health centers, have risen 23% since 2010, in spite of that demand. And visits to hospitals have gone up 93%. There's an incentive problem. And part of the reason is that it only costs you about 20% more to go to a hospital to get your care than to go to a community health center. So one of the ways to start to change behavior potentially is raise the price of getting seen in a hospital and makes being seen in a community health center almost free. That's an incentive of sorts.
So, but it gets back to the education issue. And of course, one of the problems with changing lifestyle, and we've seen it in other places, that when you prevent disease, you get people to exercise and to eat better, the case of diabetes, the case of cancer that doesn't happen, you don't see. Right? It's when you have your cancer diagnosed because of an early test, yes, I did it, I prevented a case of cancer, the patient sees it, the doctor sees it, it's a success for mammography, it's a success for pap smears. But when you prevent a case of diabetes because you exercise and you ate well, you don't see it. Yeah. It doesn't show up on your radar screen unless you kind of look at the community. So how do we raise community awareness to show people we're reaching our goal? And that's been difficult all around the world. Do any of you know of a place that's been successful in maintaining motivation where you don't get a bell to ring every time you've prevented a case of something?
I understand that, for example, in Scandinavian countries, Sweden is an exemplary example where they have a national diabetes registry. I think in some of these Scandinavian countries, there's only a few million people, everybody have an ID.
Right, all of Scandinavia could fit in Shanghai and there'd be space left over.
Yeah, but I think the fact that they have this, benchmarking, right, really transparency, of course it's anonymized, but really letting people know the performance, and so that, people can learn from these kind of quality matrices, and then, making sure that these people have access to education and care. And certainly, I think we probably might have to empower the individual, so that the individual know over the next 40 years, what is going to happen if they do this, and it doesn't happen, if they don't do this, what will happen? And then if they have their own personal diary or something like that, so that they can actually start empowering, they're empowered, with the sort of care model, or care process that they should have. And in order to sort of, make everything clear to everybody, because currently a lot of these are very mythical. The doctors don't know, the patients don't know, everybody don't know. And so, maybe this is, easy said than done, but my experience is, if a person comes to see you, they actually do want help. The ones who don't come to see you. But the point is, it is just the whole environment. I think you give me a patient, if you give me 6 months, okay, with my nurses, with my paramedics, with a bit of education, day by day, just a few messages. They don't have to see me all the time, phone calls, right, and so that I understand the need of this individual. Some of them are very complicated. They may need multiple injections. Some of them need to see a dietitian to lose weight, And these sort of, then you have a care plan, And then you can reassess 1 year later and then start seeing whether you get it or not get it. And with this, after 2 or 3 years, to change that person. And I think that's what clinical trials do sometimes. They've been in there for a few years, and I think they change.
So you thought you were going to be passive, just listening? Not true. I'm going to put you to work. You're our health ministers. I'm going to give you $500 per person to allocate, and half of that money had been spent on preventing communicable diseases, and you've controlled the parasites, and you've controlled other infectious diseases. Hepatitis is being vaccinated. You're making progress. What are you going to do to prevent NCDs? Because you can't afford to take care of them at the rate that they're happening. So that's my challenge to you. And if you're not quite sure, give us an idea and we'll bounce it off the panel. You can either ask the panel in general or ask Juliana, David, Richard, or Mike specifically what they would do with your idea. So Gary, you live in Hong Kong. What would you be doing to prevent NCDs?
Now, Hong Kong is relatively small, so it's easier to work out the formula. If you look at the different disease, of course, you have good data of the epidemiology, and then from the science that we know what sort of intervention will result in certain reduction in, let's say, mortality or morbidity in that disease. So with that, once you have all those data, and then you look at your pocket, how much money you have, and then distribute, of course, you know, the maximum benefit with the minimum amount of dollar, and depend on how much I have, you know, that's how we will work it out in Hong Kong. You know. And in China, it's going to be, you know, there are a lot of heterogeneity from one region to another region, and I'm sure if there is another extra 250 per capita, you know, the oncologist is going to say, we need the money, we're going to do this prevention, and of course the cardiologist, the diabetologist. So there has to be some sort of science in analyze that much, whatever data you have, and then to distribute them, you know, for different disciplines.
Can I just pick up on a point then? Because I think the regional element in China is extremely important. We recently did a study with Fudan looking at the prevalence of asthma, and there was wide variation across China in the prevalence. So I think in addition to...
Do you believe the data?
That's a good question. To a certain extent, I believe the data. I mean, I certainly believe that there's a variability significantly across the country, whether it's 6% or 8% in one place. So I generally believe the data. But I think to your point, Jeff, actually I think there is a real opportunity to spend some of those dollars on research on epidemiology, burden of illness, so that we really have a good understanding of the baseline, so that when we have the interventions, we can really understand what is happening. I wouldn't spend a lot of the money on it, but I think certainly some element of that should go on research on epidemiology and burden of illness.
Gary? Yeah.
Just make a comment, yes. Getting back to the asthma, you know, definitely marked variation. Of course, the highest is in the cities, while it's relatively low in the region. But unfortunately, if you look at the morbidity, though, you know, someone who developed asthma in the city are actually better looked after than someone who is being looked after in the rural region.
So there are 1 billion people in China. How do you find out what the actual prevalence of diabetes is and heart disease and cancer? Right? If you wait for that to become clinically relevant, you've probably missed a lot of cases. So do you just do a small sample? And small samples are still a lot of people. Even if you do a 1% sample, it's a lot of people. So do we have the resources to actually screen to find out how many cases there are to see if an intervention is going to make a difference?
You know, why I would argue for a national database project, it's an infrastructure project. And China is great at infrastructure projects. And when you build infrastructure like a national database, you know, the dollars per individual who may benefit become relatively low, and it gets better and better and better over time as the database gets tested. So I think part of those dollars have to be spent there.
Ping?
I'd like to provide some comments. I'm based in Peking University, returnee, spent more than 20 years in the US. Compared to the Western countries, China is unique in many ways for public health, particularly for non-communicable disease. In particular, type 2 diabetes. Why is the current situation like that? There are multiple reasons, like lifestyle change and stress, the faster pace. I think all those risk factors, everybody name it, a long list. But what's the fundamental one compared to Western countries? Is it genetic or dietary or combination, the genetic and environmental factor? We don't know. So recently, China has 2 new initiatives. One is non-communicable disease, exactly focused on type 2 diabetes and cancer and cardiovascular disease. The second one is precision medicine. Again, it's focused on this non-communicable disease. So how to allocate those resources? That's a huge amount of money for 5-year plans, maybe 10 years. They can renew, After listening to your discussion and the talks, I think the best way, the most effective way is education, linked to prevention.
So I have a question for the panel, Ping, that sort of raised. Were there cases of diabetes and heart disease that we didn't know about because people didn't live long enough because of the communicable diseases? And they're coming out now because we suppress the communicable diseases. That's one way of looking at it. Another way is that we could have suppressed the communicable diseases, but if we kept everything else the same, they wouldn't have emerged. But as we suppressed communicable diseases, we brought in a Western lifestyle. We had more smoking. We had more fats in the diet. We've got cars. We have polluted air. Which one of those factors do you think is the one that's turning the corner here, or is it impossible to dissect them out?
I think over the last 3 decades, actually, a lot of epidemiological and also mechanistic studies and even clinical trials have been conducted in both China and also Asia. And I think there is good evidence suggesting that Asians, they do have, not so good beta cell function compared to Caucasians. And maybe it's just our body is still sort of in a relatively primitive lifestyle, right? So it's just this mismatch between biology and modernization. Because really, we are talking about a very rapid changes in terms of our lifestyle within the last 2 or 3 decades. And our beta cell sort of size appears to be well correlated with the, with our BMI. So smaller people tend to have smaller beta cell size. And then also the other thing is, I think we tend to deposit more visceral fat. So, we don't look very overweight, but in fact, Asians have more fat than Caucasians, and the fat is all in the wrong place. And, this combination of atopic fat together with reduced beta cell, unmask these individuals. And that's why they have early onset of diabetes. Actually, 1 in 5 of these people with diabetes were diagnosed before the age of 40. And these people are exposed to this environment or abnormal internal environment 40, 50 years. And so, we are now having a lot of premature kidney disease and also heart disease. And kidney disease is very important in Asia. In a way, they're a bit like a small type 1, right? Because, this hyperglycemic inflammation. And then they, once they have the abnormal kidney function, then I think they further increase the risk of heart disease. So there are subtle differences in terms of the disease patterns. But they are a high-risk individuals, and certainly, genetic research has shown has discovered a whole panel of genetic variants, particularly in some of these Asian populations, which are associated with beta cell biology.
So to your point, just the fact that breast cancer occurs 10 years younger in China than it does in the West is an epidemiologic phenomena that's not really well understood. You know, even though, and this may be heresy at the WEF, but even though prevention and behavior change are essential and they're ultimately the solutions, we've got 900 million people that are smoking or exposed to smoke daily. We've got to get boots on the ground, out there in the community, educating people on any one of these things. We can't wait for a 10-year study. We can't wait for disease to progress. If you're the Ministry of Health in China, you just got to get out there and deal with it.
And also some of the studies have already shown that some of the drugs, and this is really where, for example, genetic drug and even insulin, these are life-saving drugs, right? You know, I mean, people should be on statins, on RAS inhibitors if they got kidney problem, you know, and if they're insulin insufficient, they should be on insulin. And these are, you know, I mean, we are now have generic drugs. And unfortunately, for many reasons, some of these people are still not having these kind of medications. And so I think having access to care and education and medications are essential. And that still go back to the point that we have to have that infrastructure and that capacity, you know, and not just the doctors, but this whole team of people, you know, to try and manage so that, you know, we have to start somewhere and then start growing. And I think we need to have some champions to show it. And then really let people see how they can do it. Because once, and I think people should be, you know, doctors should be encouraged to, you know, measure as they go along. And you know, not just seeing patients, but really create that infrastructures, you know, training the nurse or something like that, to set up that little registry in order to start learning themselves. And I think that's really how we should do it.
And one thing just to build on that, and maybe just we haven't really touched on it, but obviously the C in NCD is chronic. And one of the issues, of course, is adherence to therapy. So, you know, we haven't really talked about, we talked a lot, rightly so, about education and disease prevalence and burden. But once patients are being treated, and to Juliana's point, there are very, you know, leaving aside oncology to a certain extent, wide availability of very effective therapies for most of these treatments, but we have to make sure that our patients are definitely taking them and use innovative ways, new technology, to really ensure that adherence to therapy is being stuck to.
Mike, we haven't heard from you. You're the Minister of Health. We've heard about how all these folks would allocate resources. How would you?
Well, to Richard's company's credit, they do a very good job of making low-cost medication available around the world. So I think that is a good step. But you know, if the thought is to try to change behavior, this is a very, very difficult thing to do. I know of at least a few examples that could be helpul in bringing back, if we were to do the next generation or next iteration of the Barefoot Doctor Initiative. There is a very famous case study in at least a corporate culture at the company Safeway, which is a grocery store chain in the United States. And basically, they were able to actually lower their total healthcare expenditure by at least helping their employees modify their behavior. So bonuses for quitting smoking, finding ways to help them build exercise into their daily environment. And ultimately, I would say it was a rousing success. Perhaps you know, at least some of the corporate environments here could mimic that same behavior. And at the same time, I think they also, at least here in China, we still have to be able to do you know, the last mile, getting out to where patients actually are, which is a very, very difficult thing to do. But I think via clever partnerships that can be managed over time.
So one of my medical school classmates was involved in helping control communicable diseases by changing the way people used water and their water-based beasts. And that wasn't in China, but it was in the Korean Peninsula, same general area. And he said he had to change the sociology. So I think we have to do it again. You know, one was you could show the lifestyle and I can fix it. And now we've got it fixed and we've created new problems. We to change our lifestyle. So I want to thank you all for your participation, thank the panel members, and let's get people to stop smoking, eat better, exercise more, and stay healthy. Thank you very much.